Guess what? Yes, you're watching Boritzer's Bio Briefing once more right here at Think Tank Hawaii, where you're hot, but we are not. And our guests are hot and have a lot of information, data, knowledge, and eye-opening statements and discoveries and so many other things that you didn't know about, and you're going to find out in the next 50 minutes. My guest today is Professor Thomas Huang. He's head of the IVF.
Director of Laboratories at the Pacific IVF Institute at Kapolani Medical Center.
Okay, and he does all types of things that we're going to find out about today. He's going to go also into some detail, explain to us how you do genetic testing on embryos. But I think it would be proper perhaps to start off with the main source of clientele that you get. Obviously, you don't do pediatrics. So that's off the table, right? You don't do geriatrics, so that's off the table, except when you have clients for IVF or IVI that are perhaps at the age of 70, 80 years old and want to conceive.
Not quite that old, but sometimes it seems that way.
It seems that way, right? Some people wait just a little too long and perhaps haven't paid attention to time passing by. So we're going to find out, first of all, as we've tried before, to kind of, how you say, my English fails me. To kind of create a trail, if you like, a path. How do people come to the idea of IVF or IUI? What is the process? How do they come at all to your lab?
Okay, that's a good place to start. I work with couples who are trying to have children. And in the classic medical framework, when you try to have a child the conventional way and you haven't been successful for about a year, or if you're older and it's been about 6 months, if you're in your mid to late 30s or early 40s, even after about 6 months of trying, you should go see your doctor and ask if there's something that's going on that maybe we can help with and intervene to help you get a child. Because as we get older, it's harder to have children. In many cases, it's a disease process that's gone on and you haven't been aware of it, or it's simply aging. And most people don't realize that just being in your mid-30s is enough to somehow make it hard to have children. And so that's how people come to see us. They first start with their general physician, usually their family doctor, and they'll generally refer to our laboratory and one of the physicians I work with to see if we can get some clues as to why it's been hard having a child.
Okay, so it's almost a kind of a, how do you call it, a trail with different junctions, and you start going down the main path.
That's
you
right.
do several tryouts, either this or that. It says either or statements that you're looking for.
You know, there is a pretty conventional roadmap in treating infertility. The first thing you have to do usually, however, is do some laboratory testing to see if you're on the woman's side, if she's ovulating normally, if her system is working. And the same with the man. A lot of people don't realize that there are a lot of men out there who are firing blanks. And so we have to do an evaluation of the husband as well to see if his sperm are there in adequate numbers and they look okay. And then, depending on what we find, there are some simple things we can do. We can try to continue with regular intercourse and natural kinds of methods, or we can do artificial insemination where we can actually take the husband's specimen and concentrate the sperm down and inject that, it's an outpatient procedure, it doesn't hurt or anything like that, up into the woman's uterus and see if we can get the sperm further up the track than normally they would be on their own. And we'll try to basically more interventionally activate her system, if we will, with sometimes fertility drugs and things like that. And we'll take it one step at a time. And if after 3 to 6 months of simple things, you still haven't gotten pregnant, then we might consider doing something a little bit more invasive. And by that I mean we're going to maybe try to take the eggs out of the woman, take the sperm from the husband, and do what my job is, which is to create the embryos in a laboratory and fertilize them there and grow the embryos. And then we can analyze the embryos, now taking us that step further where we have access to asking questions about the embryos with respect to their genetics and other things about their health and their ability to make a child.
There are a lot of common misconceptions. I mean, one thing, things that you learn in hygiene or early biology in high school, apparently it's incomplete information that you only find out later, hey, I really didn't know A, B, or C. and so on. And,
That's very often the case.
and what I find out that also, even many women have very little knowledge, except rudimentary biology, about their own bodies. And they're unaware of some of the things you've just stated, that aging in women, even at the earlier stages of, let's say, at the beginning of the 40s or late 30s, is undergoing changes that can affect the percentage of successful pregnancies.
You're absolutely right. You know, most people don't realize that, but even 100 years ago, the average woman had her first child when she was only 13 or 14 years old. And the average woman over 100 years ago had an average of 13 pregnancies in her lifetime.
Wow.
And in the short space of just 100 years or so, our society has changed so that children are no longer thought of as producers. In the old days, they would work on the farm and they'd be part of the production system. And now they're consumers. And so we can't think about it in the same way. They're expensive relative to the way our economy functioned in the past. And women's roles have changed. Women are no longer simply child-making machines that start when they're teenagers and basically spend their whole lives either being pregnant or breastfeeding for the first 30 years or so of their reproductive lives. Now they stay in school and they get an education. They may choose to put off traditional childbearing until their late 20s or early 30s. And that's been a model that has led unwittingly and without intention to people finding, oh, it's not that easy to have a child when you're in your 30s. And they always thought that it would be okay. And that's something, in other words, we've just learned in the past 20 or 30 years. And it was not something even we as medical professionals really appreciated. And I think for most people, starting a family in their 30s is going to be possible. So I don't want to mislead people, because 5 out of 6 couples who are trying to conceive will be able to in their early 30s, mid-30s. But 1 out of 6 couples is going to have trouble. And that's simply because the biology of our systems was not really designed to have children all the time in the 30s. It was designed to have children in your teens and early 20s. And so there are going to be some people in our society who are, just based on genetic diversity, will not have the ability to as easily conceive the first few months of trying. And that's where our job comes in, to sort of see where the trouble is and to see if we can help facilitate. And that's really what we're doing, facilitating them having a child.
One of the things I noticed has been discussing this issue in several shows that we've had is that women often assume that their ability to have mature eggs is the same as men. They can keep making new ones as we speak.
That's exactly right. And you know, the flip side of that's also very interesting. Most couples, and in fact most people, think that if a couple is having children, or having children is difficult, it must be the woman's fault. And in fact, that's not the case. What we've come to realize is that maybe about 30 or 40% of the time it's the husband that is really...
Well, fair is fair, 50-50.
It's the weak link in the system. And that's not too hard to fix a lot of times, but it's something that people didn't appreciate before. But still, I would say a little more than 50% of the time, there's something in the woman's physiology that isn't working quite as well, and we have to give it some help.
Do you think there's a certain amount of hype in the popular press when you hear about a 67-year-old Romanian doctor suddenly conceiving that says, well, you know what, if a 67-year-old Romanian doctor can conceive a baby or twins, then anybody should be able to?
Yeah, you know, and more commonly what we see are Hollywood stars showing up on a promenade with single or twin babies, and we know she's in her late 40s. And everyone thinks, oh, she's very lucky and she's able to do it. And they don't tell you that probably those weren't using her own eggs. And so that's touching on another type of treatment. But unfortunately, and this is something where it's not fair, but women's eggs don't function as long as men's sperm do in terms of being produced in a healthy way. As everyone already knows, women tend to go into menopause around the age of 50. But even 10 years prior to that, starting in the early 40s, the ovary, which is making the eggs, starts to lose its robustness to make eggs every month. Usually people's periods will become more irregular. And I think more importantly, even when they do have eggs that are ovulated, What we've come to learn is that most of them, when a woman is in her 40s, most of the eggs are not chromosomally normal. And it seems that all the best eggs are ovulated in maybe in their late teens, early 20s, up through 30. And then the eggs that are ovulated towards the end of her reproductive life are probably not genetically as healthy. And that's why you hear stories of concern where women who conceive in their 40s need to be screened for, say, Down syndrome and trisomies and some of the chromosome abnormalities. Probably more than half, maybe 70% of the eggs that are ovulated by a woman in her 40s are probably chromosomally abnormal. Most of those, if they're conceived, will probably not implant, and they wouldn't make a child because that's nature's way of basically not allowing abnormal children to be born. But that also manifests itself as infertility. You don't know you're having an early abortion or a very early spontaneous miscarriage. But that's what's happening, and that's one of the reasons they can't conceive in their 40s.
I see. This kind of leads me to think that perhaps we are getting into a societal or philosophical situation where we believe that we are so in control of our biological, cultural, systemic orientations, everything that's happening on the globe, that we can eventually, ultimately control, that this should be just another factor that we should be able to control. It's almost a kind of Aldous Huxley, a Brave New World.
Yes, and in fact, when we started our program 25 years ago, the main reason, and it still is the majority of cases what we do, we're trying to help infertile couples conceive. Within the last, I would say, 5 years, there's been a paradigm shift where, because we know more about the reproductive process and the problems people have as they get older, there's been this new field emerging called fertility preservation. And this is an exciting new field. We've learned, as I just mentioned, that as women get older, their eggs don't work as well. There's a higher risk for chromosome anomalies and so forth. Now, it's possible to freeze eggs. So what we're finding are technologies that can preserve your fertility by taking eggs out of the ovary, perhaps even in your 20s or early 30s, and preserving them. We can freeze them and keep them basically in liquid nitrogen indefinitely.
Without being fertilized.
Without being fertilized. So a woman, if she's not ready to start a family, and let's say, just as an example, since I know many medical students, they're in medical school, they need to do a residency, or they're in a professional degree path, they may not be ready to start a family until they're 30 years old or perhaps a little later. And so this field is emerging in part to help people preserve their fertility by taking eggs out, or maybe they don't have a husband or a partner yet, and we can freeze those eggs. And so if you were to have problems later, we have these eggs banked to back up their fertility. That's one case where, as you mentioned, we're trying to rationally exert a little bit more control of our reproductive process. That fertility preservation technology is also very important in patients who have cancer, who have a disease that's going to render them infertile or even sterile. A very large number of women, for example, who get breast cancer in their reproductive years. And treatments for your cancer, unfortunately, will render your ovaries damaged quite a bit, and you may not be able to conceive afterwards. So that technology is also important for fertility preservation. This is a big new area, and we're real excited about it because it's a whole different population that's being affected. It's not the infertile population, but it's the fertile population that we're now trying to give new options for. So our technology, although it started to help people have children who are infertile, has some interesting new applications in that way.
Hold those technological thoughts. We'll be right back after our commercial break.
Aloha, I'm Jay Fidel. This is Think Tech Hawaii, broadcasting live from the Pioneer Plaza in downtown Honolulu. We raise public awareness about tech, energy, and globalism in Hawaii. Technology is critical to our state. A vibrant tech sector will give us new prospects in the global marketplace and will offer great careers and make our economy more resilient. Streaming live on Ustream and Spreaker, ThinkTech allows its hosts and guests invaluable opportunities to report important events and discuss important questions, and to be heard here in Hawaii and around the world. You can find links to our live streams on thinktechhawaii.com or on our mobile website, m.thinktechhawaii.com. And you can see our archive on YouTube. It's all just a click away. We want to do whatever we can to keep Hawaii relevant, connected, and thriving in the complexity of the 21st century. We hope you will help us in those efforts. Tune in today. This is Think Tech. I'm Jay Fidel. Mahalo.
You're back and you're watching our guest, Dr. Thomas Huang, professor at Department of Gynecology and Obstetrics, or Obstetrics and Gynecology. I'm sorry, I always thought it was...
Either way works.
Either way work. Having a fascinating discussion on what happens as we age. Actually, that's my area of aging, but I'm simply unaware what happens on the inside. I'm more familiar with what's going on the outside. And we are finding out that the technology is right now changing as we speak, attempting to freeze in place biological process that will make pregnancy well, not ovulation actually, right, but the achievement of pregnancy later years, especially we're talking about women who perhaps have breast cancer, might be undergoing chemo or radiation therapy, right, and perhaps unable to conceive in the future. So preserving their eggs earlier on so that they can, if you get actually a radiation treatment or chemotherapy, can you still carry an egg that hasn't been fertilized?
Well, many women can still ovulate normally. It depends on the type of chemotherapy that's used, and also perhaps the amount of radiation that you're required to undergo. That can affect how well you come through that process. But it's also important to add that a big population of cancer patients that we're really interested in are, of course, the adolescent girls, the pre-adolescent girls who are still young, who may have something like a leukemia or something like that, a blood-borne cancer. These kids, and some of them are very, very young, need to have somebody help them so that after their treatment, when they become reproductive age, they'll be able to have kids. And that's why we're really, really trying to learn more about how we can preserve ovarian tissue. And there's some exciting breakthroughs that have been forthcoming in the last 5 years, where we can take little pieces of the ovary. Because you have to remember, if a young girl who's, say, 10 years old that's diagnosed with leukemia needs treatment, she doesn't ovulate yet. She's not going to ovulate for a few more years. So we can't take eggs that she ovulates in the way we can for an adult woman. But you'd have to go in and take a small piece of the ovary. And now we can even freeze small pieces of the ovary. And so later on, when she's an adult, that small piece can be thawed out and placed back on the ovary, and it'll start to function again. And there are already about 20 or 30 babies born in the world from that procedure. It's still very early, but it's very exciting technology.
Excuse me. So we have several possibilities then for infertility issues. One is taking an egg out and preserving it for later use. Another one is having an egg fertilized and preserving it for later use. And then we have some other options for women who haven't been able to carry to term pregnancies.
Okay, now you raised the topic of whether their uterus, we're talking about a different organ now. For some women, the uterus isn't able to successfully implant an embryo and successfully take it to term. In those cases, we use what's called a gestational carrier. So if we have a couple who can go through an in vitro fertilization cycle, we'll take those embryos, and either fresh or after we've frozen them, we will implant them in a third party, what's called a third party carrier. It'll be a woman who's not biologically at all related to the embryo, but she's donating her time and her uterus to help that couple conceive by carrying the child to term. And then it technically becomes, in legal sense, it's almost like an adoption. Then the couple who's the biological parents will then have to adopt the child back, because most of our legal system is set up looking at adoption when it's taken from the woman who's the birth mother and goes to another couple, even if their own biological child is considered an adoption. So there's a little bit of legal work that has to be done, but that's how it's commonly performed now. And so that helps people whose uteruses don't function well.
Yeah, I raise this because I think that people, aside from the biological issues or the lack of information or lack of knowledge that we get as we grow up about our bodies and what our bodies can produce at what time spans, what time periods, how long will it work for, whether it's male or female. The other question also comes out is what can we change? Is there anything in this process, whether it's dealing with the egg, or whether it's dealing with a fertilized egg, or with it dealing with the renting in uterus? I mean, what can we control? What can we change? What can be some of the factors that we have power over? And one of the things I wanted to ask you about, you mentioned the production of eggs, perhaps taking an egg at an optimal period, let's say in the early 20s or perhaps early 30s. But the question is, when you try to have perfect eggs, America especially is a society that thinks it's in control of everything, would like to be in control of almost every process in the human lifespan. Is it possible through outside activity to create better quality eggs?
Well, that's a tough question to answer with any certainty. We don't have the technology right now to manufacture eggs or to create eggs from, say, stem cells. Mm-hmm. As you may be aware, stem cell technologies are very, very important now in helping in the area of regenerative medicine. I personally would love to have stem cells that can help my knee feel better, or perhaps it would make my pancreas work better if I get diabetes, or my heart to work better if I get a heart attack. The use of stem cells, which are cells in our body that have the ability to differentiate into any tissue, is a very, very amazing area right now. There have been experiments done in mice where we can take stem cells that have the ability to make eggs and use those to manufacture eggs. But it's very early in that research. And the one thing that's different about creating eggs, as opposed to, say, liver cells or heart cells, is that unlike liver and heart cells, eggs that we would manufacture are things which can make a person, a whole different person. And we have to be very careful that genetics is right, because the worst thing for us as people in this field would be to do something that in any way would be harmful or have too high a risk for any conceived child. And so that's probably the hardest part, is the ethical part, where we can find out whether the technologies we're using are safe and what kind of risk do they pose. But I do feel that both with respect to eggs and sperm, there will be technology available to use stem cell technology to help derive many of these cells that we can then try to evaluate. I think we're probably 10 years from that, but I bet in our lifetimes we'll see that technology emerge. Now, the question is, do people really need that technology? And it's one thing to be able to say you can do it, but is there a real need? And in fact, if some of these other technologies work out, maybe we won't be forced to really go to that extreme to try to generate our own set of eggs, supplies of eggs, in the same way you might see if you go into a fish store, an aquarium store, and you see fish have eggs that are outside of their bodies. I don't know if we need to go there, but I bet the technology will evolve to that point.
So you're talking about gene expression, essentially.
Yeah, we have to find a way of assessing whether the developmental program in the egg is going to be normal, and whether all of the 20,000 or so genes that we have will be expressed in the correct sequence, the right time, to make a healthy human being. And that's the one thing we always have to remember, and I always have to remind myself of this every day, is that when a couple comes into us for treatment to have a child, what they really are asking is for a healthy child. They don't want to just have a child. They want to have a healthy child. And so I think the challenge for us is to doing all we can to give them a healthy child. And that's where the technology really, that's where the rubber meets the road right now. So for example, if you look at, or if you ask the question, what is our biggest challenge as fertility doctors? One of our biggest challenges is to give the couple a single baby. Right now, we're so good at what we do in some ways is that we're victims of our own success. We get a lot of twins, for example. And if everything goes well in the pregnancy, twins are a blessing. They're wonderful. And the problem, though, is that sometimes twins pose obstetrical risks that is very dangerous if they get born prematurely or if the woman goes into premature labor. And you have to bring the babies out to long before term, then there can be a number of problems health-wise to these infants. So our current challenge is to try to reduce the twin rate in our field. And one of the ways of doing that, to sort of go back to the concept of genes and genetic expression, is to analyze the embryos in the laboratory while they're developing and to see if we can identify the ones that have a much higher chance of successfully making a baby based on the chromosome number being correct and the developmental program expressing itself correctly. And that's where we are right now. We're trying to see if we can analyze the embryos in a way that doesn't hurt the embryo, but in a way where we can tell the couple, this embryo looks so good that we're only going to have to replace a single embryo, and we're going to give you the highest chance of getting pregnant. And that's kind of where our field is right now, because without that type of a genetic analysis, we generally have to replace 2 embryos because we're never quite sure, just by looking at them, which one has the best chance of making a baby. We don't want to put more than 2 in very often, but to have the highest chance of success, given the amount of money and time that the patients have put into this, typically it's not unusual to put 2 embryos back, but we still get a fair number of twins. So we would very much like to have a technology such as analysis of the genes and the genetics of the embryo to help us get down to a single embryo transfer, which has the same success rate as 2 embryos that were not analyzed. So it's a little bit of a complicated issue, but that's currently where our challenge is right now, to use everything we can to have the couple feel they have the best chance of getting pregnant, but not put them at too much risk, for example, with twins that can have obstetrical complications.
I see. But so, basically, what are some of the available tools when a woman wants to pursue, or a couple wants to pursue, the methodology of IVF, and you want to make sure that you don't get some genetic aberration, or you want to make sure that there's not going to be some specific inherent genetic defect from history or from family history and so on. What can we do to test or improve the chances of a healthy birth?
Okay, there's 2 basic kinds of genetic analyses that we can do. And these analyses are possible using embryos that are 5 days old. We go from a single cell to 2 to 4 to 8 and so forth. And as the embryo cells are dividing, when they're 5 days old, there's about 60 to 100 cells in the embryo. And at that point, we can very safely now remove, say, 5 or 6 of those cells without damaging the embryo. The embryo can survive, if we biopsy, we call it a biopsy, of a very small sample. And then we freeze the embryo. And that sample that was biopsied can then be genetically analyzed in several ways. The first way is simply looking at the number of chromosomes that the cells have. Is it the normal number or is it the wrong number? Is it a trisomy? Does it have too many chromosomes? Is it a monosomy? Does it have the wrong half as many chromosomes of a given chromosome that it should have? And if it's an abnormal number, then we wouldn't want to put that one back in the uterus. The second kind of analysis is an analysis of specific genes. So for example, let's say that you have a certain disease, a genetic disease in your family that you know about. And a good example for here in Hawaii that we see are thalassemias. These are sort of hemoglobin disorders. And there are higher, sort of slightly higher prevalence in Asian populations. And so we see a few more of those here in Hawaii. Usually a couple will have an affected child from normal conception. And that's when they'll come to us and say, we have a child who has a genetic problem. And we'd like to have another child. We'd like the the child to have a brother or sister, but we don't want to have a risk of having them have the same abnormality. In that case, our technology is very, very useful because we can analyze each embryo and find out whether it's going to have the genetic disease or not. We will know with certainty. And that's a very powerful thing to be able to offer a couple who has already had an experience where they've had an affected child. So we can either look at the whole chromosome, which would have tens of thousands of genes on it, just to make sure that the number of chromosomes is correct, or we can get down right down to the specific gene itself. That's a single gene that we're going to be examining. So we can do these kinds of tests now. And so then the question then becomes, well, what about other traits that we might want to have? Can you select for a child that can run fast or has blue eyes or some particular trait? And there the answer is probably not. Not only is it very difficult to analyze those complex kinds of genetic traits, but it's probably not agreed that it's an ethically correct thing to do at this point. Because one of the things we have to remember is we don't want to devalue, human life. There is currently, because of the technology I just mentioned, currently we can evaluate the embryo for whether it's a boy or a girl. And that's one of the pieces of information that comes back. And so right now we're grappling with the issue. If the couple says, I want the girl embryo or the boy, do we do it? And right now, if they really feel strongly about putting a single embryo back, and they do know the gender, we'll acquiesce to their desires. And we were worried at first that it was all going to be girls or all going to be boys, but it turns out for the few cases that we do, it's about a 50-50 request. And so we feel that we're lucky that we haven't had to grapple with a problem of sex ratio imbalances being asked by our patients. It was a little bit unexpected, but happily, is about a 50-50 request. And by the way, interestingly, when people ask for that, almost always it's been for people who have one child already and they want only one more child, but they want to have gender balancing. As it turns out, it's more often requested as a balancing request, so they have one boy and one girl. And so it's turned out so far that it hasn't posed too much of an ethical challenge for us. And we don't have so many of those requests. We may get a few a year, but that's all.
Hold this thought, and when we return, we're going to talk about Chinese politics and sperm.
Okay.
Aloha, I'm Jay Fidel. This is Think Tech Hawaii, broadcasting live from the Pioneer Plaza in downtown Honolulu. We raise public awareness about tech, energy, and globalism in Hawaii. Technology is critical to our state. A vibrant tech sector will give us new prospects in the global marketplace and will offer great careers and make our economy more resilient. Streaming live on Ustream and Spreaker, ThinkTech allows its hosts and guests invaluable opportunities to report important events and discuss important questions, and to be heard here in Hawaii and around the world. You can find links to our live streams on thinktechhawaii.com or on our mobile website, m.thinktechhawaii.com. And you can see our archive on YouTube. It's all just a click away. We want to do whatever we can to keep Hawaii relevant, connected, and thriving in the complexity of the 21st century. We hope you will help us in those efforts. Tune in today. This is ThinkTech. I'm Jay Fidel. Mahalo.
You're watching Boritzer's Bio Briefings. You know the channel. You know what we do. You know that we're not hot, but you are. And you're here every time that we're here. We're happy to see you. We're talking with Dr. Professor Thomas Huang, specialist in vitro fertilization, head of the laboratory at Kapiolani Medical Center, researcher and teacher at the medical school. And we've been talking about the ins and outs of IVF. IUI is less perhaps...
what you're referring to, intrauterine insemination, is actually the most common thing that we do in terms of treating couples with infertility. And it's usually the step that precedes in vitro fertilization. So we'll usually try that since it's a lot simpler, and it's a process where we take the husband's sperm specimen and we analyze it, and we try to prepare it in a way that the doctor can basically place all the sperm that's coming from one specimen up into the uterus. It's important to first understand that when a couple has intercourse normally, the sperm get deposited in the vagina, and only about 1% of all of the sperm that are deposited there actually get up further in the reproductive tract, because most of them are left right there. They don't swim up high enough into the woman to even find an egg. And so what artificial insemination is, or intrauterine insemination, it's basically concentrating 100% of the good sperm that are in there and putting them further up into the reproductive tract with a catheter, and it's very simple. And we do many, many more of those procedures than in vitro fertilization.
Yeah, I would like perhaps the control room to show us an image of what this looks like through the microscope when you look at it.
Well, here, I think the image you have is actually of the embryo. Okay. If I'm looking at my monitor here, and if you can play there on the right-hand side, it looks like you're seeing an unfertilized egg that we did inject a sperm into, and now it's developing. Now it's a 4-cell embryo, an 8-cell embryo. That actually is compressing the first 5 days of development into about 30 seconds. But this is what we look like when we're 4 or 5 days old. And there we get a structure called a blastocyst, and that's where we stopped the video. The blastocyst is what will implant into the uterus, and it's 5 days old, and it's about 100 cells. It doesn't look like a human being at that point, but it's certainly, that particular video is of an embryo that is currently about 6 or 7 months old in someone's uterus right now. So that one actually implanted.
So if we're talking about the IUI procedure, and you say that you're able to place the sperm right on the egg.
Well, it's going to be placed high up in the uterus. And if you have to go back to your anatomy and then review the plumbing system, that the ovary is connected to the uterus by something called the fallopian tube. And the egg comes out of the ovary into the fallopian tube. We're going to put the sperm right at the top of the uterus at the other end of that tube. And so within a few hours, the sperm will go up into that tube, and that's where they'll meet the egg.
Contrary to gravity.
Oh, absolutely contrary. They have strong tails. They swim forever. You know, this is actually a useful point.
Yes.
Good quality sperm can live in a woman's body up in that area for up to 5 days. And so the reason I mention that is because many times people think that, oh, if from a contraceptive point of view, and this is actually a completely separate topic and an issue, but women think that, oh, if I have intercourse with somebody and I'm not scheduled to ovulate for 4 or 5 days, I'm probably safe and I'm not going to get pregnant. That's not true for all cases. There are many people who have documented pregnancies from a single act of intercourse 5 days prior to ovulation. So the sperm can live a long time in the woman's body if they're a good quality sperm. So you have to remember that it's not just intercourse at the time that that egg is there. It can be several days ahead of the egg and still effectively fertilize the egg.
So let's look at this a little bit from the male's perspective. Obviously, we are two males here discussing the woman's body, so we probably are not total experts on how they feel. Excuse me. But what exactly happens before you place the sperm into the tip of the fallopian tube?
Yeah, so, you know, men are all different when it comes to their semen quality. Some men who are fertile have millions and millions and millions of sperm, and that's typical. But there are many fertile men who there's a range, I would say, of concentration and total number of sperm that's quite adequate for fertility, provided that the sperm swim pretty well and they're shaped normally. And one of the things that's a challenge for us is to try to evaluate the husband to see where we think his sperm fertility really is. And so we do a semen analysis, and we take a sample of the husband's sperm and we look at it under a microscope. And we try to evaluate how good we think that specimen is. And depending on what we see and the things that we measure, we may recommend artificial insemination for some men who have, as the phrase in Hawaii would be, they have junk sperm. We say, don't even bother with artificial insemination. Your sperm are not very good looking. We don't know why. And that's really a frustrating part of male investigations, is that when men have very low sperm counts or the quality of their sperm isn't very good, almost never do we really know why. We aren't able to fix it, and we're not sure why that man has that particular problem. We feel probably some men may have been exposed to some chemicals or something, perhaps in the workplace or during the course of their lives, that has compromised sperm production. But more often than not, it's probably that's just the number they were born with, and they're just not making very many. And perhaps their fate is not really to be able to father children. And so we have to come to some judgment as to what's the best way to help them have a successful conception cycle, to have a child. And so we do look at it in the laboratory. We want to know how many he's making, how well they swim, how well they're formed, and whether there's other things in there that we can then provide clues as the best way to treat them.
But this must be a real problem in Western society where we, as I said previously, we like to think that we are in control of our destinies, whether biological, physiological, or whatever. And how do you, from a human perspective, dealing with a client as a GYN-OB person, how do you explain, explain, because people, I know that especially in the West, people will always come, but what can we do, doctor? What can we do?
Well, from the point of view of male infertility, the fact that we can pick up in the laboratory a single sperm under the microscope with a small needle and inject it into an egg, which is called intracytoplasmic sperm injection, has pretty much wiped out male infertility, because at most we'll have maybe a handful of eggs during an in vitro fertilization process from the wife. If we're lucky, we'll have 20, 25 eggs from a woman on a given cycle, though that's not typical. That means we only need to find 20 or 25 sperm, okay? And so even the most difficult, I would say, of 100 men who cannot conceive naturally because of inadequacies in their semen quality or their sperm quality, 99% of them, 99 out of 100, we can treat with in vitro fertilization because we need so few sperm.
Also, the sperm are not uniform in terms of their design ability within a particular male.
Yeah, but that's true too. But some men may only, well, let me compare and contrast a normal versus, say, an infertile man. The average man in a given ejaculated specimen may have a concentration of sperm that's around 50 million per cc. And if you look at the volume and do the simple multiplication of concentration times volume, it may be well over 150 million sperm in one specimen. 150 million.
That's a lot.
And
it
it's
can
a
overwhelm
lot.
the egg.
But even now, and if an infertile man may only have 10 million or 5 million, that's not enough actually to conceive naturally for many men.
I see. But because they simply don't find their way.
They
They get lost in the process.
They get lost in the process. You need more
overwhelming
than that.
forces, we said in the military, yes.
Most of them don't ever have a chance anyway. And you need 100 million typically to give yourself a great chance. There may be evolutionary reasons for that, but be that as it may, many men who have infertility problems naturally and who have very low sperm counts may only have a few million sperm. But I may only need 10 or 20 in the laboratory.
Now,
so
how do you do this?
We overcome that process or that limitation, because when we process the sperm, we can put a drop under the microscope, and we have micromanipulating tools that we can use. They actually have joysticks and robotic arms, and we go in and we can actually pick up an individual sperm.
Yeah, this is my question.
Yeah, we pick up an individual sperm, and then we can inject it into the egg and basically engineer the fertilization process. So that's been a revolutionary breakthrough in treatment of male infertility. And it was discovered by an Italian doctor named Giampiero Palermo about 15 years ago. And it basically has all but wiped out male infertility as long as we get a good number of eggs and the wife has good embryo quality. Those people will usually be able to conceive.
Now, what happens if you place two sperms in the same egg? Is that twins?
No, that's an abnormal egg.
I see.
Normally, only one sperm should get in.
Okay.
And so the woman will not have, well, twinning is sort of a complicated issue, but if we take two embryos from two eggs, that are injected separately
Yeah.
and put them back in, you'll get twins
Twins.
if they both take. And they'll be non-identical twins.
Right.
Identical twins is a
Fraternal,
different, that comes from a single embryo that splits.
Splits, right.
Yeah. But anyway, going back to the male side, yeah, that technique called intracytoplasmic sperm injection has essentially revolutionized our ability to treat men who are normally infertile.
What I'd like to actually end our segment today, I want to talk about some of the ethical issues surrounding this whole idea, excuse me, of human beings controlling
Yeah.
the, quote, God-given process. And could you address some of the issues that IVF and IUI and making decisions on how to fertilize an egg and so on? What are some of the ethical issues you're faced with every day?
For those of us in medicine, we generally think of ourselves as people who are trying to alleviate suffering and help people overcome medical adversity. And certainly infertility is that. The challenge comes because some kinds of infertility are probably genetic, and other kinds of infertility are not. It may simply be that, I'll give you the most classic example. If you're a woman and you've had a sexually transmitted disease, you've had chlamydia or gonorrhea, some sexually transmitted disease early in your life, your fallopian tubes get blocked because of scarring from the infection. And so the sperm and the egg will never meet. So it's not a genetic problem. It's something that's been acquired. And IVF was actually most powerful to overcome that kind of infertility because the sperm and the egg can never meet. So we do that in the laboratory. But by conceiving a child with that couple, we're not going to have a child who's born from that procedure who's going to have infertility because it really wasn't a genetic problem initially. But there are many cases of infertility that are probably genetic. Some of the real severe male factor problems where I said the man may only have a few million sperm. Very often those are probably genetic conditions. And by conceiving children for that man, for example, if he were to have a boy born from that procedure, there is a significant chance, we don't know what that chance is yet, but there's a significant chance that that child will also have infertility. So we may be unwittingly passing infertility on to the next generation from the treatments. The problem is we don't know for a fact that that cause of infertility was genetic. But that's an ethical issue. Are we passing on infertile conditions? And so to address that kind of a question, it's really part of a broader question in all of medicine. We keep babies alive who are born, say, at 25 weeks, who would normally never be able to survive, right? But our technology keeps them alive. We save young children who have leukemia or cancers who historically would never survive. And it's very possible that many of these have some genetic origin that we don't completely understand yet. So actually the entire field of medicine always is dealing with, are we saving people, helping people, so that when they become reproductive age, are we passing genes on that led to their condition initially? So this is one of these very, very thorny issues. It's extremely hard to say to a couple, we're not going to treat you because we don't think that's the right thing to do, but we may not know. And so that's at the heart of so many genetic issues these days. And I think it's also clear from what we know that heart disease, diabetes, all of the diseases that are affecting us as adults later in our lives do have some genetic basis. So is it more important for us to screen all the embryos that we're creating so that they're not going to get diabetes or heart disease or certain kinds of cancers if we could screen them out? So we're on a slippery slope. There's no question about it. And I think that's what makes our field so interesting and challenging, is that there really are no absolute answers here. We're going to have to just move into this field carefully, slowly, and discuss it in ways that our profession does, which is we have ethics committees, We're constantly looking at outcomes, and we're saying, is there an issue here that we have to be worried about? And perhaps like the FDA warnings on your bottles of medication, maybe we're going to have to put a label that says, okay, if you do this procedure and you have a baby, here are some risks for you having a child. And I think that's all we can do. And we give them an informed consent. I think we have to give a couple the choice. I don't think we as doctors are going to be able to say, absolutely, we're going to do it or we're not going to do it. But I think what we can do is give the couple the information that they have, and then they can make the choice.
Medicine as God in our society. Tremendous question, been raised consistently in the last 50 years, and I think we haven't solved it today, but we'll continue looking for the answer.
It's not a problem that you ever get a complete solution to. It's a dialogue, it's an ongoing conversation.
I thank again Dr. Thomas Huang, our guest today, professor at the Departments of Obstetrics and Gynecology, University of Hawaii School of Medicine. We really appreciate your knowledge and your giving us your thoughts on the complex topics of pregnancy, birth, when it's possible, when it's not possible. Until next time, you've been watching Boritzer's Bio Briefings. We hope to see you once again on Think Tech Hawaii Television.